Dr. Kevin Hedges is a registered occupational hygienist who is certified in both Canada and Australia. He has a history of working in occupational health research and practice in the mining industry. He is also past president of Workplace Health Without Borders, a member of the Canadian Aerosol Coalition, and has been an occupational hygienist at OHCOW for more than 5 years, and has been a great partner with a number of us in putting together these Occ-COVID sessions throughout our time. So thanks very much, Kevin, for joining us this time to talk about what tools we have in our toolbox to prevent transmission and exposure in this season, right? So I'm considering this season the holidays as well as winter and going into people coming back from the holidays to get back to work. So go for it. Thanks.
Thanks, Val. What a relief I got back on. My screen froze and I managed to get back on. So it's all's good. Thanks so much, Ryan and David and Jen, for donating your time. I've got a few slides, but I'm a quick talker, so here goes. First thing, SARS-CoV-2, it's airborne. And just want to acknowledge Dr. Jennifer McDonald as well for doing such great work. She's been interviewed lots, and she's also going to be our last presenter. But both Jennifer and Sarah and other authors actually recently got this paper published in the Canadian Medical Association Journal. So this team have done a great job in Canada for really pushing the airborne transmission recognition. Now with Omicron, I'm not going to go through this table, but there's a lot of questions and it's not looking good. We haven't got a lot of information now, but I really just want to refer back to, Mario Possomai and, talking about the precautionary principle. It's really more important now than ever. This was a study that came out of a quarantine hotel in Hong Kong. And what they demonstrated that the index patient from one side of the corridor infected somebody from the other side of the corridor. So, it passed through the corridor, and this was Omicron. And, the paper notes airborne transmission across the corridor is the most probable mode of transmission. And this is, a slide from the science table that was recently released. And I just made a note there, additional public health measures. We need to do much more than what we're doing at the moment. So I want to talk about, carbon dioxide as a tool. I want to just provide an overview of risk assessment calculators. I actually want to really focus on simple calculators that everyone can use. And I want to provide some guidance and solutions that we can all apply. Firstly, with regards to carbon dioxide, there's a lot of discussion, a lot of debate. We tend to look at 1,000 ppm as a kind of a limit now. That's the OHCOW kind of limit. But it's also around reduced test scores in classrooms. So, reducing CO2 below 1,000 also benefits children in many ways. And I actually held this on an airplane coming back from overseas, and I just watched the device go up over time. It's very hard to distance in an airplane, so it really just reinforced the importance of wearing a proper respirator in the airplane. I've got a friend and colleague, Todd Irick, who's in the Ottawa clinic. Kevin, you really need to measure the carbon dioxide more than 2 meters away from you. It's actually quite difficult in a plane, but it's a very good point. So when we're measuring carbon dioxide, we really need to be careful that we're not measuring somebody's direct breath. And when I spoke to Lisa Brossu, Dr. Lisa Brossu, has been an international stalwart. She just made note that nobody's correlated carbon dioxide with particle concentrations. It might be a bit of a surrogate for ventilation, but it's not a direct measure about the ventilation, and it tells you very little about air patterns in the room, which was kind of the finding in this Chinese restaurant, Guangzhou restaurant. So it's really about turbulence as well. So beware, not representative risk-related to non-airborne transmission pathways, doesn't account for recirculated air that's undergone filtration. doesn't consider other control measures, such as the use of masks as source control, nor the use of respiratory protection, nor contributions of CO2 from other sources. But if limitations are well understood and a precautionary approach supports CO2 monitoring as a useful and relatively low-cost tool to make real-time assessments of relative infection risk, which lead to improvements being made to improve ventilation. Measurements should be taken at multiple locations, and a building-wide system with a central reporting and monitoring is desirable in all spaces with high occupancy. And this is something that Val Wolf shared with me actually this morning. It's a fabulous infographic coming out of France, and it really paints a great picture. So really we want to aim below 600, and really no more than 800. And once you get above 800, it's in the amber. And then when CO2 goes above 1,000, we shouldn't really be in that workspace where we're not being protected. This is just a slide that I've put a screenshot from an article from New Zealand, where they're actually putting carbon dioxide monitors in schools now as part of a ventilation toolkit. Now, this is really for the hygienists, the engineers, the HVAC technicians, and others. If you have a monitor that monitors for 24 hours, continuous monitoring, you can actually look at the slopes of the curves. And I'm talking about if there's like a steady state condition, there's not that many interferences. You've got the same number of people that have been in there, and there's not air coming from other places where there are people. You can actually look at decay curves over time to estimate air changes per hour. And I was talking to a colleague of mine, and it might be worthwhile even putting an AeroNet in the school at the end of, like, just say for a 5-day period, and then just monitor the curves and do calculations, and then maybe do averages to estimate air changes between each day, just to get a better estimate of air changes. When we've got risk tools, we've got more comprehensive tools, and so the whole idea of having these tools is really to try and find out where we treat the higher the risks, and we want to treat them first. And this is just the International Society of Indoor Quality and Climate, and this was a webinar provided through them, where they did a comparison of a number of different comprehensive tools. And the tool by Jose Jimenez, who actually presented at OHCOW 1 or 2 sessions ago, his tool's getting a lot of attention. But once again, it's a very comprehensive, it needs a lot of information. And also out of Australia, Lydia Maraska has a pretty useful tool too. But once again, it's quite a comprehensive, detailed tool. We did have Leon Wang, Professor Leon Wang, present on his tool called City RPI for indoor airborne virus transmission. And I've just provided a hyperlink. You might want to watch that again because it's quite fascinating. This is really for building owners and users, so you can actually look at graphics, starting off with the country and then homing in on, then looking at the city and then looking at the building and then putting in different interventions to see what the risk, the level of risk is. This is hot off the press. This is from the AIHA, which, by the way, actually received a $600,000 grant from the CDC. So they're really busy trying to develop a lot of tools. And this is an exposure assessment tool. And they're actually pulling some papers together for the Journal of Occupational and Environmental Hygiene. And it'd be remiss of me not to mention John Odick's classroom ventilation tool. We actually did a workshop this morning, which I thought went pretty well, actually. There's lots of discussion. And this is a really useful tool for teachers, and to post the output of the tool, which is an Excel spreadsheet as a form, on the outside of the room. So, they can look at how good the air changes per hour is, and then it's kind of openly communicated with their colleagues. And this is just, you know, if you do nothing else after this presentation or in the next few days, please watch this video on the tool, and I think you'll be quite taken back by it. So now I just want to talk about simple tools. Of course, OHCOW has the regional risk tool, and I noticed that I just kind of put Sudbury in there. You can actually select different regions, and I've put Sudbury, and you can see Sudbury's going through a troubled time at the moment, which kind of correlates to what Ryan was just saying. But really, when it comes down to it, you know, we do a risk assessment every day. When we change the tires on our car, we actually don't change the tires on the main road. We'll probably, if we get a flat, we'll probably turn off the side road and we'll get away from the other cars, you know, which is the exposure. So if you think about Japan, you know, posting this very early in the pandemic, avoiding the 3 C's, you know, you can basically look at closed spaces, crowded spaces, close contact settings, overlap the circles, and then look like right in the middle and say, well, do any of these situations apply to you? There's a group called OHCOW from Australia, dear to my heart, and they actually talk about the three V's and a T: venue, poor ventilation, vocalization, and time, as being ways to sort of figure out where the risk is. And the AIHA talk about duration, density as risk factors, and dilution and distance as risk mitigation factors. And Dr. Lisa Brossu is doing a fabulous job, you know, leading the way forward. So she's actually leading a ACGH pandemic response task force, and she's really pushing the control banding approach. And this is kind of an infographic that really talks about exposure levels and hours per day and what needs to be done with regards to, do we control that source, pathway, or receiver? And this is also an infographic led by Lisa, and it's provided on the CIDRAP site, but it really compares, you know, surgical masks to non-fit tested respirators. And you can see how much of a difference it makes, how long, you know, you can wear a respirator for before you're infected compared to, say, a typical surgical mask. But this is actually for the original variant. Somebody's actually modified this approach for Delta, and obviously the time's a lot shorter before you come infected. But you can see the SM with the circle is a surgical mask. The N95 fit tested, by the way, is a respirator, and just how much better it is if it's fit tested compared to not being fit tested. And this is kind of a bit technical, but I'll just give you an overview of it. This is a paper looking at different scenarios. So when a person's wearing, right on the left there, that person's wearing a fit tested or adjusted respirator, and you can see the mean infection risk is 0.14, and far on the right, the person's wearing a surgical mask, and you've got an infection rate of 10.4. So the infection risk can go up like 100 times just from wearing those two different face coverings. I think also, you know, we have a Canadian standard, and if we actually go through the process flow diagram, it actually takes us to this control banding wheel. So we have something in Canada, you know, around selection, use, and care of respirators. And it does actually point us to using either a air purifying, which is an N95 or better, or a power purifying respirator. And I kind of shake my head and I think, why aren't we using this Canadian standard, which is a national standard? Now, just for some simple calculators, this is a kind of a very useful calculator from Harvard T.H. Chan. And what you actually do is you have these scroll bars and you look at the different controls and you pull the bars across, and you'll see on the left where I haven't actually factored in N95s. You know, and at the top you can see there's a red bar which shows the risk is quite high, 11%. And then on the right hand side, as soon as I factor in N95 face covering, very likely the risk reduces to less than or equal to 1%. There's a number of other interactive tools. This is in the CDC, on the CDC site. Select the options to see how particle levels change as you adjust ventilation settings. This is another one, the National Institute of Aging. It's very good if you're kind of looking at, going to an event, a Christmas party or somewhere else, just to see what the risk is based on, the situation. And this is another tool too, through the NIST virus particle exposure and residences. Another one too, from New York Times, just a guide for look at your risk in your country. Another one from the CDC, looking at the risk levels if you're thinking about traveling. And this is also just a piece in Washington Times, I believe, that talks about, the different risk factors you might want to look at as well. And, I really think it's important to go back to the OHCOW information and look what we have. And I did talk this morning about really good information coming from OHCOW, International Practice. So they're an Australian organisation, and also the World Health Network. The World Health Network has a really useful graphic. And I think I was sort of talking this morning about, assigning a COVID-19 guardian, even in a classroom, who perhaps opens the windows for 10 minutes once every hour. And you can sort of see it there. And, I just also want to mention our last speaker, Jen McDonald. And, so I provided the hyperlink to her presentation here. So you'll watch it at the end, but you can come back, and she really reinforces the whole approach about good, respiratory protective equipment, looking at filter fit and function. And that's me. Thank you very much.
Thanks a lot, Kevin. He covered a lot of ground, but there are so many different factors to consider, but there are also factors of influence then, right? That so if you do something about any one of the factors, you've improved protection or prevention. There were a few questions. One of them was around, I guess, the importance of remembering that the OEL for carbon dioxide is 5,000 parts per million. And so, of course, saying that 1,000 is the max we would like to tolerate from an OHCOW perspective in terms of worker health perspective and occupant health, not just worker. So I don't know if you wanted to comment on that.
I used to hate really long, lessons like that go for 2 or 3 or 4 hours. And I used to feel very tired, and I used to think, I just really feeling tired, and sometimes I kind of couldn't concentrate. So I really, we need to rethink the whole paradigm around, what's an acceptable carbon dioxide level indoors. And as John's alluded to, there's so many more benefits than reducing, the risk from being exposed to COVID-19. So if we can look at, 1,000 ppm as being a target, we're going to achieve a lot.
I can add to that if you don't mind.
Please do, David. Yeah.
So the 5,000 limit is I see it as an occupational, like industrial type of situation, such as if you're working with dry ice and you're looking at pure CO2. If we take a ventilation perspective and say, well, our ventilation standards require us to have a certain amount of outdoor air, we can back calculate from metabolism and air changes what the limit should be to have at least the minimum amount of required outdoor air. And that's far lower than the occupational limit. In fact, it's around 1,200 parts per million. And then there's the effects of cognition kind of started around that as well. But it's kind of there's different types of research have shown different things. It's a little harder to show it with pure CO2, but when you use it within a classroom type of situation or where there's cognitive tasks, it's not necessarily the CO2 itself, it's all the other stuff that's accumulating in the environment that could be affecting cognition as well.
Yeah. Thanks. Someone's already going to pick up the KN95 masks for their family even before we show them Jen's presentation, and she will be joining us by phone as well. So it's a good segue. I don't know, we did make reference a few times to the workshop this morning on our classroom ventilation tool, which I think Vonnie also put in the chat, and we did record that session. It's a more in-depth dive into the tool, and in particularly where to find the information, including as John says, he showed us 7 different ways to be able to infer, if not calculate, an airflow for the room, or to be able to then help you calculate the rest of it and how many air changes you're getting. And so it will be available on our website